So what I'm going to do is I'm going to give an overview, first of all, about the prevalence really of domestic violence and abuse and how it affects people with disability. And then we'll move on to our main speakers. In terms of, having questions for the speakers, if you can use the Q&A function, that would be brilliant. So then we should be able to cover the questions. Okay, so thanks. And while I'm just waiting for the first slide, I'm pleased to let you all know that we're just engaged in some research in domestic violence and abuse in women with MS at Leeds Teaching Hospitals and the University of Leeds. We were very lucky, actually, to get a award through the Horn Family Foundation in Canada. And the award is to investigate, first of all, with a PhD in Leeds, to investigate the experience of women with MS and domestic violence and abuse. And then we'll have a second PhD in Nottingham who will engage with healthcare professionals in MS. And then we'll have a postdoc starting next year. So we're hoping that this work is really going to influence policy. Okay, so it's a really important time, actually, and very timely that we're doing this webinar, because we are right in the middle of the 16 days of action, the White Ribbon campaign, which is running until the 10th of December. And actually, you can see at the bottom, one of the aims of what we're trying to do is get comfortable talking about it. And that's something that Noreen and Rachel are going to help us with. So just looking at the figures, this is from our National Crime Survey in England, that 5.5% of 16 to 74-year-olds experienced domestic abuse up to March 2020. So this is pre-pandemic. We must remember that this isn't gender specific, although in our crime survey, white women were about twice as likely to experience domestic abuse as white men. And in the last year, about 1.6 million women suffered domestic abuse in England and Wales. So, this is not a small issue. And I think it's an issue that may be going a bit under our radar as healthcare professionals in MS. So, interestingly, I wasn't aware of this report, and many of you may not be aware of it either. So this is a report from Safe Lives, and it is about disabled survivors. So it's about disabled people and domestic abuse. It was published in 2017. There are some really, concerning figures from this report, which shows really in 2021 compared to 2014, almost twice as many disabled women experienced abuse. And from this report, women with disabilities are 7 times more likely to experience sexual assault than those without. So you can see the prevalence of this and why we need to be particularly concerned about our population living with a chronic condition like MS. So this is just a bit more detail from that report, and looking at the difference really between people with disabilities and the higher rate, if we look on the left, of attempted suicide for people who have experienced domestic abuse. Also, I think if you look to the right-hand side of the slide with the timer, you can see that disabled people tend to experience abuse for a longer period of time. So that is concerning, and especially because we're the frontline contacts of these people. So I think, that's why we need to sort of raise our awareness and also develop our comfort in actually addressing this. Interestingly, people with disability are more likely to experience abuse from a current partner or from an adult family member. So this is really, if you want to look at this report, if you look at Safe Lives, it really highlights the issues that people with disabilities have in this area. And then what really raised my concerns about domestic violence and abuse was in the COVID-19 pandemic. So obviously people were isolated and potentially isolated with their abuser. And globally, so not related to disability, but globally, cases were reported to increase by 20% between March to September 2020. A third of specialist services reported increased requests for support. You can see that calls to the domestic abuse helpline also increased by 20% in this period. But I think what's really important for us to realize, so, you know, it's almost as if these figures are the tip of the iceberg, because a lot of people don't report. So in the Safe Lives survey, 2/3 of victims felt unable to seek help. So, you know, we're seeing this significant increase, but that's obviously in reported cases. Okay, so the aims of our webinar today are to understand how domestic violence and abuse are defined. And then from our perspective as MS healthcare professionals, how do we investigate and manage domestic violence and abuse? We're going to learn from Noreen and Rachel about adult safeguarding and the Care Act of 2014. And then Noreen and Rachel will take us through our learning really in the context of the case scenario that we've got today. So I'm going to move on next. I'm not sure that Heather has joined us yet. So if I move on to just go through some of the definitions with Heather's slides. So we'll just have a quick slide change. But I think one of the things about the definitions is we often think about violence, and abuse is much more than physical violence. So I think that's one of the things we need to be aware of, that there are many different ways to abuse a person, which isn't only physical violence, although obviously physical violence is part of that. So in this shows all of the different issues of well-being, and one of those is about protection from abuse and neglect. And there are so many different principles feeding into well-being, but actually feeling safe is a huge part of our well-being. So this tells us about the definition of domestic violence and abuse, and it is controlling, coercive or threatening behaviour in people over 16 or over, and it's people who are intimate partners or family members. And I guess it comes back to the point is it's regardless of gender or sexuality. And you will all know about coercive control, and I wonder if actually we're more aware of coercive control in our MS clinics, because there is that potential for a change in a relationship and a change in the balance of power over a partner. So these are the different types, and I think it's important for us to consider all of these types. So we may think mainly about physical abuse, but psychological and emotional abuse may not be as obvious to us, and then sexual abuse may not be reported. And then of course there's financial abuse. So this plays into the kind of controlling behavior. And then I think we are all probably, you know, aware of the potential for neglect, but again, this may not be something that is obvious to us. We need to think about honour-based violence in our different communities, and also modern slavery. And, you know, this is something that I think, you know, the safeguarding leads in our own organisations are very helpful actually in bringing us up to date with some issues that, you know, we may not really be well aware of. So there are different forms of physical abuse, and this slide just illustrates them. You know, it isn't necessarily just about the first point about violent actions, but it can be about restraining somebody. It can be about different physical sanctions. I mean, someone can actually remove someone's ability to walk, for instance. You know, I've had cases where someone's walking aids were removed from them, which completely restricts their independence. And also misuse of medication can also be a form of physical abuse. And then psychological or emotional abuse. And often we see people with considerable mood disorders in our clinic, don't we? And you know, obviously changes to their emotional state. And I wonder if sometimes actually we don't look underneath that, so we see people with considerable anxiety and depression, and are we perhaps thinking that's a reaction to MS without actually thinking that is there anything else going on? And I suppose part of what I hope that we take from this webinar today is just increasing our awareness of, you know, there may be other factors which contribute to a presentation, for instance, of anxiety and depression. Okay, and this slide just illustrates all of the different forms of psychological or emotional abuse. And you know, I was thinking about our webinar over the weekend with the awful case of the child Arthur, and actually not forgetting how manipulative some people can be. So it can be difficult for us to get to this, and I think Noreen's very much going to help us sort of understand around it is important to get the opportunity to talk to the person with MS by themselves, so that they have a chance to actually explain if, you know, they are subject to any of this coercive behaviour. And of course, sometimes it can be framed in the context of someone saying that they're trying to do the best for the person. And so I think we just need to be aware of that. And then sexual abuse can take the part of any sexual act. It can be sexual harassment. And again, it's important for us to not make conclusions about people's sexual activities, you know, for women with different levels of disability. So, but we must be aware that there is a potential for abusive relationships. And then I think this is an important issue, because this is again around yourself, your view of yourself and your independence. So financial and material abuse, and this can be related to your financial affairs or possessions or benefits or theft, and obviously sometimes people can be, you know, subject to internet scamming too. Okay, and then there's neglect, and so this can start to come to the forefront. And I wonder again if in hospital service, so I'm a hospital-based neurologist, Noreen is hospital-based now but has a lot of experience in the community, and Rachel is also community-based, and I wonder actually, do we pick up more of the neglect and acts of omission in the community, and how do we alert ourselves in hospital-based practice? So just in summary, and this will lead into the next talk, so it's important just that we don't just think about physical violence, you know, that we think about abuse in many different ways. We talk about people being vulnerable, but don't forget that this isn't just based on levels of disability. This can happen to anybody. So I think don't think that only people with severe disability are potentially affected by different forms of domestic violence and abuse. And disclosure is difficult, and that's why I think the figures that I showed you at the start are probably just touching on the surface of what can be going on. So it's so important for us to be vigilant and to learn about what we should do really if we suspect we suspect domestic violence and abuse, or if it's disclosed to us. So we just should be moving on to, yeah, so this is now, you know, the really crucial section now from Noreen and Rachel potentially, which is around how do we actually investigate and manage domestic violence and abuse. So thanks very much, Noreen, for going through this with us today, and we're looking forward to sort of learning a bit more how we do this in practice.
Thanks, Helen. So actually researching about doing this webinar today, actually it's been a real eye-opener over the last 2 weekends. And when I joined earlier on, I actually said to Helen, oh, I saw the online advert for your PhD study. This looks amazing. And actually there is so little data out there about domestic violence in MS, which actually is really shocking. But I did find this was a NARCON's survey from last year, looking at the prevalence of domestic violence with people with MS in the States. And actually what was really shocking was that they wrote out the whole of their database, and actually over 1,200 people, and only 200 people responded. And actually, I think it really fits well with our scenario today, because predominantly it was psychological abuse that came out top, with financial abuse and neglect second, with physical abuse and sexual abuse much further down the line. But I think that was really quite telling. But the demographics of this group were, people who'd had MS for a number of years. So I think the mean was sort of 21 years. They it didn't talk about EDSS, but it talked about disability scale and, higher disability. In their mean age was 51. So I think this is really sort of quite interesting. Actually, it's, I'm really excited to hear what comes out further down the line from Helen's project, because it's really good to see what the picture would look like in the UK. So what can we do as MS healthcare professionals? And I think, as we've already talked about, we need to be aware of the signs of domestic violence abuse. And really, we've got to take that mantra that every contact counts. We know our patients really well. And, that's really important in being able to recognise the risk factors. When I did a literature search, there was lots of stuff about GPs picking up signs of DVA, and I think there is a GCP module that GPs can do to learn more about it. But it's about recognising those risk factors. It's knowing our person with MS. Are we concerned that there's any signs or symptoms that there could be an issue? Are they looking unkept? Are they looking stressed? Really good point from Helen about, are they low? We're always looking for signs of, problems with mood and problems with cognition, but actually you're going to be, if you are a victim of DVA, you're probably going to be quite low in mood. You're going to look worried about being with that person that's with you. It's looking for those physical signs, such as obviously, obvious signs like bruising and things like that. But it's looking about signs: is somebody well hydrated? Are they malnourished? Certainly, I've had cases where we've been contacted by third parties concerned that somebody doesn't seem, they're worried about their hydration risk. But also, you're recognising those risk factors in the caregivers. So, are they looking stressed? Are they looking like they're not coping? There was an interesting statistic about the risk of somebody being a perpetrator of DVA if there's any history of alcohol or substance misuse. So, are there signs there with the caregiver that we should be concerned? And I think we really need to utilise our rapport and our relationship with our people with MS to be able to allow that disclosure, because it's almost being able to allow yourself to be in a situation to hear those cues that somebody might be giving you, that they want to open that discussion. We need to ensure that we're aware of our local services, so we know who our safeguarding teams are. We certainly use our safeguarding lead a lot if we've got concerns. And I think even being aware of where are those specialist domestic violence support teams. So if someone does disclose DVA, we need to be able to listen and take care not to blame them. We need to acknowledge that it's taken strength for them to talk to somebody about it. We need to give them the time to talk, but not push them to talk if they don't want to. And I think that's really challenging. We've all got, huge time constraints in clinic, but I think the more research you do about this, the more you can tell that actually you're not maybe going to be able to do all of this in one day. You've got to acknowledge that they're in a frightening and difficult situation. And we've got to absolutely reassure somebody that nobody deserves to be threatened or hurt, or, despite what their abuser might be telling them. And we need to allow them to express their feelings and allow them to make their own decisions. I think there's lots of, this was from the NHS NHS website, but actually the same was reflected through gov.uk and through the different domestic violence charities that are out there. You can't tell somebody to leave a relationship if they're not ready. It's got to be their decision. But I think mainly we're trying to ascertain that if somebody has suffered physical harm, then we need to encourage them to seek medical advice. and be able to support them if they want to report this to the police. But actually, and it's about knowing the different organisations and support that's out there. And there is a lot. I now probably have set an alert for myself. I've been on every website over the last 2 weekends. I'm waiting for little random emails to start popping up asking me, have I got a problem? So during the disclosure, we want to make sure that this discussion is somewhere private, ideally without the suspected perpetrator. And I think Rachel and I, when we were preparing these slides, that's really difficult now. We're doing so many more consultations by telephone or video call that somebody's there. It actually probably was easier if you were seeing somebody in clinic face to face, that you could send that other person off on a can you go and book this blood test, or take this outside to make the next appointment. It's actually it's probably even more difficult now than ever to be able to have that private discussion with somebody. We so have to respond with empathy and understanding, and we need to be able to listen carefully and question sensitively. But I think it's validating those responses all the time, and really important to be able to record everything. But we do need to be mindful. Lots of us now are using electronic patient records, and you've got to think about what access or visibility there are. So it's being able to document everything, but without maybe that other person being able to see what you're documenting. So after a disclosure, safety's got to be priority. Is that person safe? And I think, being able to say to that patient, do you feel safe? Are you worried about going home is so important. We need to make sure that we're aware of our professional guidelines and our local policies, and certainly the Data Protection Act, thinking about with regards to sharing information. So we should be gaining consent. We should be asking that person's consent to be able to share information with relevant people. We need to be able to tell them who we're going to share that information with and when. But we also need to be aware that actually the Data Protection Act doesn't mean that we can't share information if we think that that there is an issue with that person's safety. We need to come up with a formulated agreed plan. So, thank you for disclosing this. I'm going to need to discuss this with X, Y, or Z. And then we absolutely have to liaise with other health and social care professionals involved in their care. So say, for example, in this scenario, I would be trying to look at when we're coming up, it's whether or not that person's got a care package, whether or not they've got a social worker. And, absolutely, I would be doing this in conjunction with talking to my safeguarding team. I think Rachel's on the call. I'm going to hand over the baton to Rachel.
I just want to go through the signs and indications when you should consider safeguarding. Often we see, when we see patients in clinic, we've kind of built up maybe a relationship with them, so we will know and have that instinct if there is something wrong. And so we're looking for sort of low self-esteem, and that can happen over time. Also, when they're disclosing to you that they're feeling that the abuse is their fault, that they're the burden, and that maybe it's their fault that they're being abused in the first place when it's not. Also, physical evidence of violence, such as bruising, cuts, broken skin, or broken bones even. And this is where we need to kind of link in with our colleagues that, if there is a care package going in, having that good communication between us and them, so that they'll highlight anything like that as well. And also being aware of when they're in clinic, or if you're doing a home visit, of verbal abuse and humiliation in front of others, because you can see a change in the patient sort of when things are being said, or if you ask a question and they're maybe jumping in to answer the questions and not giving them a chance to answer for themselves. Also, when a patient does disclose that there is abuse going on, whatever kind of abuse it is, there is often a fear of outside intervention. And I think it's really important that we share with the patient that we're there for them to help make their life better and support them in living independently as well. And also, that they should be aware that everybody has a right to feel safe in their own home, and that they feel safe, and that's not asking for anything too much. We all should feel safe in our own home. Also, when we're doing home visits, is having, as we do when we do go into home visits, is that you're getting a better holistic kind of view of what's going on as well, looking out to see if there is damage to property, or even different kind of bits of equipment that have been put into the home, if they've been damaged, wheelchairs, hoists, and even sort of slings and things like that, just keeping an eye out on these different things as well. One of the main things, big things that is a big red flag is if they become isolated and they're no longer able to kind of have contact with friends and family, which, when somebody is sort of very disabled, they're dependent on other people taking them out or allowing people to come into the home. So that's another red flag that we should be aware of. So obviously there's the safeguarding, and the aims of the Care Act 2014 is to prevent harm and reduce the risk of abuse or neglect to adults with care and support needs. It's to safeguard individuals in a way that supports them in making choices and having control in how they choose to live their life, and making it safeguarding personal to them. And we'll go into that more as we go through the scenario at the end of our call today. To promote an outcome approach in safeguarding that works for people, resulting in the best experience possible. And also to raise public awareness so that professionals, other staff and communities as a whole play their part in preventing, identifying and responding to abuse and neglect. So the 6 principles of enshrined in the Care Act 2014 are empowerment. So it's important that that personalisation and the presumption of personalised decisions and informed consent as well. And also prevention is better to take action early on. And I think, it's like when we're building up that relationship with our patients, that they feel that there's that trust of it as well, that they can come to us with things if there are anything that they're worrying about. So it's easier to deal with these things early on. Proportionality as well is the least intrusive response appropriate to the risk presented. And often, sometimes when we think of abuse, we're thinking of removing that, that's when that could be the last thing we're thinking of. It's about diffusing situations. If a carer is maybe at the end of their tether, and as carers and partners take on that role, it can become overwhelming as needs increase. So it's about being aware of that as well. Protection is support and representation for those in greatest need. So looking at how we can support people and help them to remain at home safely. Partnership is local solutions through services working within the communities, looking at sort of respite for people to kind of give people a break from each other. Can we go back the slide, please? Thank you. Yeah. And also sort of being able to detect and report neglect and abuse early. Accountability and transparency in delivering safeguarding as well, and that's our note keeping and making sure that we're documenting everything properly. That's and that we work in partnership with the patient. So Noreen found this great safeguarding app online for England. We couldn't find anything similar for Scotland, but there's a lot of good advice and signposting on this app, and a way of reporting and guiding people to kind of manage reporting and just giving them empowerment and how to go forward with a complaint or a report. So I found this quite good as well. It's the 5 R's of safeguarding, where all staff have a responsibility to follow these 5 R's, and that's recognising when there is abuse, responding to that, and reporting it and recording all the information appropriately and referring on, so that we're as a professional, we're not carrying that whole responsibility, that it has a multidisciplinary team approach to that report. That's Noreen. I'll hand over to Noreen.
I think this was in the lovely safeguarding document that's freely available on the app and on the NHS England website. And it talked about this holistic assessment. So if we have done, we're all used to doing our holistic assessments, looking at the physical and emotional status of our patients, but it's really, if we have got safeguarding concerns, that we are thinking about patients' views and wishes. We're looking out for those inconsistencies in the history of explanation. There's a really nice question in the chat about falls being a big part of advanced MS, and how do we know whether or not a fall is an accidental fall or there's something more to it. I think that's going to be about our questioning of our patients. Is there a really good reason? If there's not a good reason, then we have got to have that suspicion in the back of our minds. We're looking at skin integrity, hydration, personal presentation. Do they look tongue-capped? Are they somebody that's a frequent DNAer for no good reason? But also we're always having to think about whether or not our patients have got capacity. We're very aware that cognition can be an issue with MS, but it's whether or not they've got that capacity to be able to decide that it is still wise to stay with that person. We all know that people can make unwise decisions, and I think it's a really big part of domestic violence that it goes so underreported because people they're worried about speaking up, and actually underneath it all they probably still do love that person. So I think capacity is a really big thing, and if they don't have capacity, then we need to think about making sure that there is a documented MCA, and that we are thinking about whether or not we can use UNCAS. Are there others at risk? Are there children involved in this, or other vulnerable people? And thinking about whether or not we do have to, is there a crime that's been committed? Should the police be informed? Preserving any evidence. And certainly in the past, when I've had a few cases I've been involved with, actually it's been social services, OTs that have been really good about helping to back up the case and work out whether or not we do need to inform the police or not. And actually sometimes it is a case of being able to give that option to that patient. Do you want to involve the police or not? Again, reiterating the fact that any action has to be that's been considered has to be proportionate to the risk that's been identified. We always have to take into account cultural differences or religious beliefs, and always have to have a valid reason to act. Is there a valid reason to act even without the patient's consent? Certainly when it comes to risk. So reflecting back on our scenario today, 48-year-old woman with advanced primary progressive MS. She confides in us that she's been physically, sexually and mentally abused by her husband. She's wheelchair bound, her EDSS is 8, so she's very likely to be being hoisted as well, and relies on her husband as he's her carer, and she's relying on him for all of her activities of ADLs. And I'm sure we've all got patients just like this. So, the big question was, Rachel, what do you think we should be doing in this case? I mean, absolutely, we want to be able to talk to this patient alone if we can, and really pick apart, why, what she's told us, picking apart the detail of that, okay, I'm listening that you're telling me that this is happening. So, try and unpick the details, isn't it?
Yes, definitely. Yeah, definitely. And that can be kind of difficult if you're in the home, but if it's easier probably in a clinic setting, but in home, you're having to get the partner to leave is more awkward, and you have to do it very sensitively.
Yeah, and I think it's validating their concerns. It's making sure that they understand that you do know what they've told you, and then being able to question sensitively to sort of get a really good understanding of the situation. And sort of, but being able to openly ask that question of, are you in immediate danger? What do you want to happen? And I think that's the hardest thing, isn't it? Because sometimes you're not going to be able to solve this whole problem in one visit. But if you like, it's almost scoping out what's happening and then being able to come up with that plan to how we're going to tackle this situation, isn't it?
Yeah. And sometimes maybe the person doesn't want anything to be done. They just want to maybe even discuss it with us. And, once that trust is built up that they are going to be involved in this and they're not going to run off with this on their own, then that's maybe
because people are
for
often
them
worried about getting other people involved, aren't they? They're worried
Yeah.
that they're going to get that person into trouble. They want to tell you that they're worried, but you know,
definitely.
I've seen both sides of the situation where actually they were saying they did want other people involved, and another where actually no, they didn't want anybody else involved, but they just wanted to they wanted to put that message out that they were concerned.
Yeah.
And I think it's about us feeling that we can, you know, we've got a, you know, a really fortunate position with people that they can confide in us, but then they're also trusting us to then refer on and get other people involved, you know, as, you know, proportionate to the situation, isn't it?
Definitely, yeah. And also, you know, that if we make it clear from the outset that we have a duty of care to them, if there are things that are going to be disclosed that they're in immediate danger, that we'll have to act upon that. And you're setting out the boundaries from the start. And also, you know, getting their consent and as well, and sharing that this is not just going to be on ourselves, that we may have to inform other colleagues that are involved in their care as well, so that everybody's, you know, able to support her as much as possible.
So I think in this situation, we would both, you would expect that this lady would probably have some other carers going in. So I suppose you're really utilising them to become your eyes and ears as well. It's talking to their social worker, so whoever has put that care plan in place, and depending on really what that investigation then comes up with, then it would depend on what happens in that situation, isn't it? Because I think you were telling me you have been involved in a couple of cases very similar to this, where actually things did go down a very formal route, didn't they?
Yes, yeah, and it's hard when you've built up that kind of relationship with the couple as well. But our ultimate responsibility is the safety of that individual, and you know, and it is difficult. And I think it's one of the hardest things we do in our role is having to do this. But I think if we explain properly to people why we're doing it and the reasoning behind what we're doing, that it's to support and to keep them safe, because it is hard for carers as well, you know, because they're in that, sometimes, you know, partners are thrown into that caring role, and they just, it's just not for them, and you know, resentment can build up and all these things, and it's easy to judge for us. And I think that's where it's really important to get that holistic history of what's going on, so that, you know, going forward we can support the two of them, you know, so that if need be, if it is that there's that carer exhaustion and kind of, you know, that we know for sure what's going on.
And in this situation, you know, it could take it could go two ways. So either you end up in a situation where, you know, you have got the safeguarding team involved, you have got maybe a domestic violence advisor involved, and actually, you know, you're in a case where you know, somebody could be removed from that situation. But it could equally go the other way, depending on what you're finding, that you would probably come up with a plan for, you know, respite for the carer, you know, increase the care package, you know, have more, you know, more ways to try and support that couple through a difficult situation. And it can, and that really is the whole crux, that it can go either way, can't it? I mean, I think we've both had, you know, we've both had other people in our lives that have been, you know, victims of domestic violence, and we're very aware that this can go in either direction. Yes. But I think we have got that underlying, we have got that duty of care, and sometimes that duty of care literally is to report on that concern. You know, that there are other specialist teams that can take this on board. This is not all on our shoulders, even though these are absolutely the people, aren't they, that you go home and you worry about the situation. And I think it's being able to be aware of all those other people around that we can actually get involved in this situation And I suppose really awareness is the biggest thing to reducing, you know, the incidence of this happening, isn't it?
And seeing these kind of wee red flags at the beginning, you know, and nipping them in the bud is really important, kind of just to, and I think opening the door for that person to come forward if there is an issue, and, you know, acknowledging that the situation where a 48-year-old woman is being looked after by her husband, you know, and it is stressful and it's hard for people to be in these situations. So it's acknowledging that as well. And then, you know, I think as clinicians, if we do that, then we're more likely to even maybe get the carer coming forward before it reaches this stage. Maybe if it is due to carer exhaustion. I mean, there can be abuse going on without having that in this scenario as well. But
and the other context is the care for ourselves as well, because actually, if you are in this scenario and this does come up, you know, it's being able to have that. You know, to be able to have that support from your team around you, or that support from the safeguarding lead, because actually, if you're involved in a case like this, you know, it takes its toll on us as well, isn't it?
It does. And I was in a lone role before, and still am, but, you know, and it is difficult because you've got nobody in that office to go and kind of debrief. So it is important to have that wider team that you can sit down and have a debrief afterwards and just make sure that everybody's okay. Because we do carry these things with us, and it's hard not to when you're seeing these situations. But it's, as you say, it is important to kind of have that self-care as well.
Yeah, absolutely. Shall we go, Helen? Shall we go to some of the questions, because some really good questions in there?
Yeah, I think that would be great. So I mean, in the Q&A from Julie has flagged up this project called J9, and I don't know if Noreen, you or Rachel or Heather has joined us now as well, are aware of this project. But certainly I think, you know, part of doing this webinar today is around increasing awareness and you know, obviously finding out what else is out there in terms of supporting people who've experienced or who are survivors of domestic violence and abuse. So thanks very much, Julie, for flagging this up. Noreen, Rachel, are you aware of this?
This comes up, actually that project comes up when you do look at domestic violence in the UK. It was certainly one of the sites that I had a really good look at. And I think I was saying to Rachel earlier, what was really interesting about all of the websites that were aimed at informing people about domestic violence, and we've got a couple of them on examples on some of the next couple of slides. What was really interesting was there were ways in the corner of the screen that you could close down that screen really quickly. So I think it's about knowing what's out there. And yeah, absolutely. You know, it was really interesting to actually see where domestic violence wasn't really referenced. Does that make sense? So it was a case of actually having to look for it. It does make you think about what could we build into the MS world, that there are more ways to signpost people to this kind of information. And
then Julie's made another point, it is around how people who are victims or survivors often stick by the perpetrator and tend to play down the violence.
Absolutely, and I think absolutely we see this all of the time, don't we?
And it's really difficult when patients are kind of, they see themselves as being dependent on that person to break that. And in some ways it can become like a perverse normality for them, you know, because they're so grateful for the care that they're willing to put up with that, you know. And it's, you know, I think as clinicians, it's ensuring that they feel safe in their own home. They're not feeling anxious, and because I mean, it's a right we have to be in our own homes and feel safe. You know, when we close that door, that we feel safe in our own home.
And then from Margaret, this situation, and I don't know if any of you have come across this, and Heather, do chip in as well. And this is where a partner is the carer, but has got a relationship outside the marriage or partnership as well. So How have you seen situations like that?
Yes, I have. I have had a situation like that, and it's really difficult because, again, you know, you've got to be very sensitive about this as well, because the situation I had, the partner had power of attorney as well for the individual, so it was really hard to deal with. But we eventually we got advocacy involved to kind of support the individual, which was really good because that kind of gave her a voice to be able to kind of speak up for what she wanted, what she felt. And it was really difficult because there was children involved as well, so that made it a little bit more complex as well. But I think it's about giving that individual a voice to be able to kind of say, and we've said it in the previous slides, about giving them, you know, finding out what they want and what's important to them, and being able to try and support them moving forward with that. Because it's very difficult, because the person can come across as being very, you know, can just go into themselves. That's what I felt. That patient just went completely into themselves and wasn't able to had no confidence with this other person who was coming into the home as well. So I think it's a really tricky one, but I think it's about, we're there for that individual and to support that individual and to validate their concerns and help them act in how they want to move forward with this, empower them to kind of make these decisions, which are hard to do without a long-term condition in the court as well. You know, it's difficult.
Yes, it's difficult. Okay, and then Jason has made a useful point about utilising the local women's refuge. So I think, you know, the more that, you know, we work together as MS healthcare professionals, and you know, we hopefully in our research we are going to be hearing in depth from women with MS about their experience. But as I said at the start, we're also going to be investigating this from the healthcare professionals, and actually learning from each other around what works, but also learning from our own local situations, and who we link up with. So, I mean, Noreen, I think you've got just a few slides to finish. Is that right?
Yeah, and there was a point in the chat about the fact that men are very much, you know, can be affected by domestic violence as well. And actually, my lasting case that I've never forgotten was the case of a chap who, you know, at times that there was a degree of abuse from his wife, and that was a really tricky situation to deal with, you know. And she was both sort of physically abusing him by sort of, she would when they would have a row, and she'd sort of hit him over the back of the head with his crutch, which was not good. And, you know, 2 children in the house. And actually that was a really interesting one, because that was probably the first case that I thought about safeguarding concerns. But actually, you know, what it turned out to be was, from the police's perspective, that this was most definitely, you know, because the patient had capacity at that point, and you know, they were engaging, and actually it turned out that they were giving each other as good as they got, really, which was terrible. You know, it was a really tempestuous relationship, but the police really took the line that this was domestic violence and not the fact that it was a safeguarding of a vulnerable adult. But it's the one case that's always really stuck with me. So absolutely, you know, male patients are absolutely as you know, at risk as with our ladies with MS. Holly, can you move on to the next slide? So I've got a couple of examples of different websites. So Refuge, who've got a helpline. Citizens Advice had an awful lot of information on there, and Women's Aid. And then on the next slide, there's some really useful other groups. So, you know, absolutely there are support groups for men who are victims of domestic violence as well, LGBT, and, you know, good old NHS England with our Safeguarding Adults Guide for Health, which we've probably all got in a very safe place from when we've been for mandatory training there. And that's really where the app comes in, that all of that information is on the app as well.
Okay, no, thanks very much. And I mean, thanks, Noreen, for gathering this information together. And I guess it might be useful if we're able to at least to send this final slide to our participants so that they have access to this. And I hope that this is just really the start of us, you know, flagging up this really important issue about domestic violence and abuse for the people with MS that we look after, and helping us just to understand, you know, your great advice around how we tackle this. And you know, as I said at the start, you know, we're doing this webinar in the crucial 16 days of action time, which continues until the 10th of December. And this is really around us not being afraid to tackle these issues, but, you know, learning how to do it in a sensitive way. And also, I think, you know, Rachel's point around, you know, thinking about yourselves as well, and support that you may need when you're dealing with very, very traumatic situations, and following up some of the tips we have around, you know, obviously linking up with the local safeguarding teams, but also, you know, the local Women's Refuge and other organisations that are out there that Julie mentioned to us as well. So I think, you know, I think these webinars are great for us all to learn from each other and to highlight issues, and then hopefully we can, you know, find another way actually of supporting the people with MS that we all work with. So thanks very much to our speakers. Thank you to Noreen and Rachel, and unfortunately Heather, there was I think an issue with Heather joining, so thank you, Heather, for...
I'm really sorry, I felt I haven't contributed at all. It was really interesting. I did want to just give a more general overview about domestic violence. Yeah. I'm afraid we've missed my opportunity there.
Well, don't worry, Heather, because I presented your slides.
Oh,
so,
did you? Oh, yeah, fantastic. So, I don't feel quite so bad.
Yeah, so thank you for preparing the slides, and I presented them for you. So thanks, everybody, for joining the webinar today, and I hope that it's raised some issues, and we'll have a look at any other comments that are coming through in the Q&A and chat, and we can always respond to those afterwards. And also, obviously, our contact details are available through the MS Academy. If anybody is particularly interested in talking about this work with any of us, that would be fantastic. So thank you, everybody, for joining today. Thank you, and thank you for our panel. Thank you.
Bye-bye.
Thank you. Bye.